This is the main talk that I'm doing today, is on distal humeral fractures. Thanks, Steve. Now, distal humeral fractures affect over 2% of the population, and there are two groups of patients that have these fractures. The one is the high-impact younger patient after an accident, and the second is the low-impact elderly osteoporotic fracture after a fall from standing. And the treatment is different for these two groups. We must remember that one of the key points of these fractures is we have medial and lateral rows on the distal humerus, and these form a tie arch, rather like a Gothic arch or a Roman arch. And we must maintain at least the medial column in order to achieve stable results afterwards. And treatment must be aimed at stable anatomic reduction of these fracture fragments to allow the patients to mobilize early. It must be stable enough that you can start early mobilization of the patient, otherwise they become stiff. We again have a problem with osteoporosis, metaphyseal comminution, and a very poor soft tissue envelope, which is bad for healing. So the treatment can be non-operative, it can be open reduction internal fixation, and it can be arthroplasty. And the arthroplasty can be a total elbow arthroplasty or a distal humeral hemiarthroplasty, which has been found in recent times. But remember that the complication rate for open reduction internal fixation is 32%, and the complication rate with total elbow arthroplasty is about 37%. So we really need to find some ways that we can minimize the outcomes of this. There are many classifications based on basically similar to the proximal humerus, on the fracture fragment configuration and the vascularity, particularly of the capitellum. The fracture patterns can either be transverse fractures through the shaft, and particularly be careful of the distal transverse fracture, which is essentially an intra-articular fracture and has a very bad outcome for healing. I'd urge you all to look at these two papers and to read these two papers. These are two landmark studies which were done. And the first was by David Ring and Jesse Jupiter in 1999, and the second is by Sean O'Driscoll in 2005. And these really, I think, define the treatment of these fractures. Our aim is to convert this fracture here to this fracture here without providing too many complications. The non-operative treatment is really indicated only for completely undisplaced fractures, patients that have advanced dementia, very low demand patients, and patients that have comorbidities that contraindicate surgery, and patients that refuse surgery. Des Loge and others last year, they looked at 33 patients, mean age of 77 years, mean follow-up of 37 months, and they found nearly 70% of good results and about an 83% union rate. And a low complication rate. The problem is that the patients are immobilized in 90 degrees flexion for 6 weeks and then have a functional splint for 6 weeks. And in an elderly person, this is quite demanding and leads to great disability to them. We look at operative treatment. I operate on the patients in a lateral decubitus position. I think one of the faults people make is that we try and tether the arm too badly. The best way to do it is to put a pillow on the side of the patient and just put their arm freely on the pillow. It allows you to be able to manipulate it better, and it gives you a very stable position in which to do it. I think you should use a tourniquet if it's a complicated patient. Once you have your approach and you've released the ulnar nerve, you can release the tourniquet, but you should at least start with it. We do a posterior incision over the medially based over the olecranon, and then you have to decide on the triceps what you're going to do with the triceps. You can have the triceps on approach or the triceps off approach, and the triceps off approach can be an olecranon osteotomy, and this is what I would advise for people that are not certain of what they're doing. It takes longer to do. There are few complications of it, and it gives you by far the best exposure. And this is the key to the thing. It is to fix the fragments. You need to be able to see what you're doing. The problems with the olecranon osteotomy, it's very difficult if you need to convert to a total elbow arthroplasty. It does maintain the collaterals. The triceps on approach is the least morbid to the patient. It gives the best mobilization, but it is very difficult to see. And I think if you have any intra-articular fracture, you should rather do an olecranon osteotomy. However, with supracondylar fractures, we can get good results with the triceps. And here's the triceps on approach that I would use. I do a posterior incision. I use what we call the trap approach, triceps anconeus reflecting split. And what you do is you incise the triceps 2/3 medial and 1/3 lateral. You extend your incision laterally through the anconeus fascia or the FCR fascia, And what this does is it maintains your medial column and your collateral, which is the most important of all. You do sacrifice your radial collateral, and this can lead to instability, but you also have very good triceps function with it, but you have very poor exposure of the intra-articular surfaces. And really, I wouldn't advise this for an intra-articular fracture. Triceps off, we've been through, it has a good thing. The indications for arthroplasty for these fractures are elderly patients, very low intra-articular fractures who have a very high risk of arthritis and avascular necrosis, multi-comminuted fractures, and patients that have, as I said, a very high risk of AVN. The overall results are good, but the complication rate's about 37%. Infection is high because of the proximity to the skin, instability, myositis, heterotropic ossification, nerve injuries are common, and loosening is a problem in the elbow because it is actually very constrained on both sides. So therefore you get rotational instability with them. Just a brief word on heterotropic ossification. I've spoken to the oncologist around our hospital there, and the current belief that they've told me is that you need to have one dose of radiotherapy, which is done with less than 12 hours after the surgery has been performed. So the patients, if you're worried about heterotropic ossification, they should go from your surgery to the radiotherapist, and they do one shot, I think, of 6 rads, and they've shown no problems with wound healing, but a markedly reduced incidence of heterotropic ossification. Hemiarthroplasty was first introduced in 1940 with the Cuda prosthesis, the sort equestria, and more recently has been given popularity with the latitude prosthesis. And the reason for this is that the latitude incorporates the radial head into it. There's a lot of work being done recently in hemiarthroplasty, and the advantage is that it preserves the bone stock. It preserves your radial and ulnar articulations. You have less restriction on activity. The patient's mobilized soon. It's easier to revise, and it can be done with a triceps on approach. The problems are that there's very little evidence or experience to support it. They're not approved by the FDA in America as yet, and there's only 100 cases reported worldwide in total up until this stage. There are only 2 studies to support them. One is by Herman, and he did 7 patients only with a mean follow-up of 36 months. He found a high rate of complications in 5 out of 7 patients, but they reported good results overall after the complications were dealt with. Radness and others last year also, 18 patients, mean age of 78 years, mean follow-up of 35 months. They had 1 complication, again, 70% good to excellent results. So if we look at hemiarthroplasty, again, you do the lateral decubitus position, the pillow. I do the triceps on approach, the trap approach. We leave the attachments to the epicondyles, very important to do that. And if the epicondyles are fractured, then they must be repaired using a figure of 8 with sutures to provide a tension band wire type technique to fix them to it. It's really important that you do it. If you can't repair those condyles, you must then consider conversion to a total elbow replacement. You can only currently use the latitude prosthesis because it's the only prosthesis that incorporates the radial aspect of the thing. And it's very important to reference the height of the prosthesis to the olecranon and the transepicondylar axis of the condyles. And you must always check that you're parallel to the posterior humeral axis. And these are indicated for younger, high-demand patients with very low intra-articular fractures or multi-comminuted fractures with a high risk of AVN. Open reduction internal fixation still remains the gold standard for it, and this is the key to it. And if you do this well, then you don't need the other forms of treatment. And what we aim for is we aim for anatomical reduction of the interarticular fragments. We aim for medial and lateral column reconstruction, and most importantly, you must restore this arch, this Roman arch which is there. The humerus, the distal humerus, is the keystone of the arch. And if you don't have this structure here, the keystone there, then the arch will collapse. And if you do maintain this medial arch, you can then get good results with it. And if you have attention to detail, then you can get very good results, and you can get as good results as with arthroplasty with it. But the failures are due to inadequate fixation or prolonged immobilization of your inadequate fixation. So the limitation is the fracture fragments to the humeral shaft, not the intra-articular fragments. We focused on this before. It is the humeral fracture fragments, the distal fragments to the shaft. And as I say, you must maintain the arch. So this is what you try and aim for, is to get these results over here. The operation is performed in 5 steps. We start off with articular reduction, then plate application, provisional fixation, distal fixation, supracondylar compression, and then final fixation. And it's very simple. If you follow the absolute protocol step by step, you'll end up with a reasonable result. The technique that I describe from O'Driscoll is different from the AO philosophy, because in the AO philosophy, you fix the articular fragment first with a headed screw. You then fix the distal fragments to the shaft with 2 plates, placed 90 degrees to each other, and then the plates are placed in a medial and a posterolateral configuration. The problem with this is it does not provide that arch support. You end up with a fragment here and a fragment here, but there's no compression of that arch there. And this is why I think the work done by Sean O'Driscoll is key to these fracture reduction. So there are 5 objectives. Every screw must pass through the plate. Every screw must engage a fragment on the opposite side that is attached to a plate. In other words, the fixation of this fragment is to that plate, and this fragment is to that plate. Each distal screw should be as long as possible to engage the fragments that we have. Each screw should engage as many of the articular fragments as possible, and the screws in the distal fragments should lock together by interdigitating to create that stable arch. And this really is the fixed angle construct that we need to achieve. And then finally, the plates must be applied so that compression is achieved at the supracondylar level for both columns to allow for union. And the plates must be strong enough to resist breaking or bending before union of the fracture occurs. So slightly more detail. Step 1, the articular reduction. Don't strip the soft tissues. Place K-wires right in the subcondylar bone as far as you can, just to stabilize the fracture, to get the articular reduction of the fracture fragments. Step 2, you must transpose the ulnar nerve to get it away from the plate. Place the lateral plate as posterior as possible to avoid damage to the common extensor origin and the lateral collateral, and insert the K-wires into the oblique holes of the plates, and you can replace these later without drilling them again. Step 3 is to insert the 2 distal screws, 1 screw there and 1 screw there, and these engage the distal fragments. And you compress with a towel clip from that fragment to that fragment before you put your screw in. Not after you put your screw in. Your screw must stabilize the fracture. If you don't compress it, your screw will end up being too long. So you must compress it either with a towel clip reduction clamp or a reduction device. The 4th step is the supracondylar fixation. And again here, what you do is you back out these shaft screws that you put in, the temporary fixation shaft screws. You compress the fracture from there to the plate, and then you re-drill another compression screw in the shaft there. And you do the same, you repeat it on the opposite side. And on each side, you put a second shaft screw in compression, and then finally you replace the diaphyseal screws which are there. Step 5, remove the K-wires that were the temporary fixation and place screws through that construct. If you have metaphyseal bone loss, you can accommodate a loss of between 1 and 2 centimeters of metaphyseal bone and do a supracondylar shortening procedure. But it's very important to align the rotation of the condyles and get that correct. Post-op, manage a patient in an above elbow back slab. You have high elevation and drain for 24 hours. If it's a high energy injury or there's severe soft tissue damage, then you must immobilize the patient in full extension for 3 to 5 days, because in flexion you get compression of the venous structures and the swelling is much worse. So you can safely extend for 5 days. Start physiotherapy at 5 to 7 days, and they can use the hand after 7 days but not lift more than 1 kilogram for 6 weeks, and they can't drive for 6 weeks. But they must start early mobilization. There are complications: stiffness, failure fixation, nerve injuries, skin problems, infection, AVN, heterotropic and post-traumatic arthritis, but these, with careful attention to your surgical detail, should be avoidable in the last thing. So the pitfalls are that the interfragmentary screw fixation of the fragments must be through the plate and not to separate those fragments from the plate. The initial K-wires must be placed subchondrally so as not to impede on the plate, and you must use targeted guides. We must avoid as much as possible of soft tissue stripping. And if you can maintain any blood supply to the soft tissues, those interfragmentary things, it's important. This is one situation where you have to trust the plate. I know that Andrew's spoken about the clavicle plates and things like that, but in this situation, if the plate doesn't fit, you haven't reduced the fracture. The plates will always fit these fractures, and you must bring the fracture to the plate. If you do that, you will reliably end up with the anatomical reduction. And you must avoid perpendicular plates because their fixation is not so good. I was going to go through trochlear fractures. So in conclusion, we need to assess each patient again, as I've said before. We need to assess whether they need to be non-operatively treated or go through to a total elbow arthroplasty. Non-operative treatment only for the elderly unfit for surgery. ORIF is still the gold standard and should always be your aim. Hemiarthroplasty for the younger high-demand patients, but there's only 100 patients here. There's no studies that are even close to 5 years, and we don't know what the long-term outcomes are going to be. Total elbow arthroplasty in elderly patients with comminuted fractures or low intra-articular fractures. And overall, with strict adherence to the principles and creating the stable arch as described by Sean O'Driscoll, or arthroplasty, and we should expect good results and early return to function in these patients. Thank you very much.
Yeah, double thank you. One for the last talk and this one. Thanks very much.